Today's session that I'm doing is about sepsis. So it's it's a topic that comes around now and again. Currently, we're in a bit of a lull. COVID, which is a form of sepsis, obviously has taken all the headlines really. Before I start the presentation, what I'd like to do is just to ask two questions. The first one is that would anyone like to hazard a guess as to defining sepsis? Does anyone in any room want to just have a go at defining what sepsis is in maybe a short sentence or two? Don't all jump to the microphone at once. Anyone want to have a go?
Infection.
Rocky's going to have a go.
No.
All right.
Well, current definition says that sepsis is a dysregulated post-response to infection or inflammation.
Yeah. Okay.
Associated with organ dysfunction.
Yeah. Very good. Okay, so my second question is, what amazing therapies do we have in intensive care to improve outcome for patients with sepsis? What specific intensive care treatments are there to save lives for patients with sepsis? Anyone have a go at that one?
Non-intensive care. Absolutely none, Dr. Parker.
Very good. Okay, so that's probably true, to be honest. So yeah, I'll bear with me. I will try to share a screen and get this presentation running. Okay, can you see that?
Yes, we can see.
Excellent. Okay, so this is not going to be about the pathophysiology of sepsis. I think that's a talk in itself. It's more about the clinical management of sepsis per se. So I'm going to spend however long it takes, really, half an hour, 40 minutes, if that's okay, on this topic. I've been the Trust Sepsis Lead for about 6 or 7 years now, so I've seen a lot of changes over that time, and UHL has had a lot of challenges, particularly around quality improvement with sepsis. So it has been a bit of a journey for this trust. We have been in and out of the headlines for not all the right reasons over that time, and it is something of a major topic for us. So what we're going to talk about is, why is it so important? Definitions of sepsis, which we've covered already, which is great. Risk factors, the initial management, ICU care, something about the future, probably talk about the complications of sepsis a bit, and have a bit of a Q&A as to if anyone wants to ask any questions about it. So why is it important? The guy on the right is a guy called Tom Ray, who about 18 years ago was treated in another hospital in the East Midlands. And if Alex Keesham was in this meeting, he would know him because he was a medical student on the ward when he was being treated, and vividly remembers the screams of pain from this man on a daily basis over a very prolonged period. And I think Tom had some very straightforward streptococcal sepsis that evolved And as you can see, he spent a long time in intensive care and ended up with very profound disfigurement and limb loss. And his life story has been turned into a movie called Starfish, if anyone wants to see it, which came out about 5 years ago. In the UK, it's estimated there are about 260,000 cases of sepsis, with about 50,000 deaths. 15,000 preventable. I think it's probably less than that now. I think it's probably 8 to 10,000, possibly. I think over the past 4 or 5 years, there has been an improvement in mortality in the UK. But there's still a lot of mortality associated with sepsis. So there is still probably about 5 to 10,000 preventable deaths. What does that translate into? In UHL, that's probably about 1 a week. So there are potentially still lives that could be saved within our trust. It's estimated about a £16 billion cost to the economy. And as I say, there's a huge amount of morbidity, both physical and psychological, which we'll go into at the end, that survivors have to live with. Aside from that, it does tend to be on the radar at CQC inspections. They use it as a bit of a barometer of the quality of deteriorating patient care, particularly towards things like giving antibiotics within an hour, that sort of thing. There's no longer a sequin associated with sepsis, but NHS England still remain very interested in the quality of performance. And it's now increasingly unacceptable in courts, either through litigation or the coroner's court, not to adhere to NICE guidance, the UK Sepsis Trust recommendations, all of those sorts of things. So anything not adhering to best practice does tend to land us in somewhat hot water. Okay, so the kind of risks. NICE in 2016 released actually a lot of guidance around the management of sepsis, and a lot of this can be found on the NICE website. But the kind of standard risk factors, diabetes is a massive risk factor for patients developing sepsis. And in fact, if you talk to David Jenkins in microbiology, he will tell you that about 1/3 of all positive blood cultures that they have are from diabetic patients. It's rightly top of the list here, and that's particularly an issue for Leicester, that has a higher proportion of diabetic patients. Obviously, older age is a risk factor, and obviously immunocompromised patients, and that may be due to things like hematological malignancy or drugs like chemotherapy or steroids, but also I would probably put heavy regular alcohol use onto that list as well, and its mechanism being through relative immune problems. And then obviously anyone that's debilitated with a recent severe illness, or has had trauma, has had recent major surgery or pregnancy, or has been recently pregnant within the past 6 weeks, and very young children as well, are designated risk factors. Definition, as was rightly said earlier on, so this came out in 2016 and is the sepsis 3 definition, so the third go at it internationally. So an international sort of round table of experts have sat down and described sepsis as a life-threatening organ dysfunction caused by a dysregulated host response to infection. Okay, so 3 important components to that: organ dysfunction, dysregulated host response, driven by an infection. Okay, and that is the standard definition of sepsis, and the clinical working definition that we use at the bedside has been derived from that. So the same paper that came out suggested that organ dysfunction could be measured by SOFA scores, and actually then moved on to use a quick version called Icu SOFA, and retrospectively identified this based on mortality rate of 10%. And this was retrospectively done by looking at observations mainly in the USA of databases of electronic observations. And that's how they came up with the QSOFA. More about that in a moment. So, you know, when we talk about at the bedside, so you've got to have, this is all based on suspicion. The problem with sepsis is that you can't wait to get a concrete diagnosis before you start treatment, because otherwise the horse has bolted and the effectiveness of treatment won't be there. So you always have to treat on the basis of suspicion and then de-escalate down the road if it's not the case. So you're using clinical data, you're using history, examination, immediately available investigations to formulate an image, a picture of whether someone's got a high likelihood of having an infection. Okay, it's not based on waiting for blood culture results or anything like that. It is clinical. And then organ dysfunction really is, as I said, originally it was based on SOFA scores, but they are not clinically usable in ward environments, in emergency departments, because it requires too much data to generate. So the QSOFA was derived. A QSOFA is made up of just 3 elements: respiratory rate, blood pressure, and a coma score. So it is a kind of early warning score system, really. In the UK, what's happened is that we have derived other mechanisms through our early warning scoring systems that have come about separately. And actually there is probably waning evidence to suggest that QSOFA may, as I've said, based on US data, is maybe not as good as what we have in the UK. And the other advantage is that the National Early Warning Score is obviously embedded into all trusts across the country, is familiar, and actually probably identifies patients at risk really quite well. So that, or derivations of that, so the red flag sepsis, which is in place in UHL at the moment, comes from the UK Sepsis Trust, and is essentially a series of triggers that are based on observations within new National Early Warning Score that score 3 or more. Okay, so they become red. SIRS I've just put in as the old sepsis 2 trigger, and that has long gone, and we don't look at SIRS anymore. Okay, so depending on which of those scoring systems you use to identify organ dysfunction, that gives essentially, we've cut out whether or not this is due to a dysregulated host response, which is difficult to establish initially. But that will tell you whether or not you've got a suspicion of sepsis. And if that organ dysfunction is present, then risk of death, depending on which one you're using, is in the order of 10 to 20% plus. Okay, so this is a predetermined high risk population that need our attention. I said, so currently within UHL, it is about to change within weeks. So that clinical suspicion plus a red flag, until proven otherwise, red flag sepsis, and we need to crack on and treat. What are red flags? As I said, so the red triggers on EWS, so respiratory rate 25 or more, a new need for oxygen, a blood pressure of less than 90, heart rate over 130, no urine output for 18 hours, or a urine output of less than 0.5 mils per kg per hour if they're catheterized. Now that is not part of news. A patient that's not alert on the new ACVAPU. Now this, I've underlined this because this is the one thing that's done really badly in clinical environments in ED and wards when looking for red flags. People, the clinical staff, nurses, don't do very well at recognizing patients with new confusion. So there is something called a squid. You need to do a squid if you think that's on all patients really, which is the single question to identify delirium. And a squid just basically means that whenever you can, you talk to people that know the patient to establish what their normal level of cognitive function is, so that you can know if what you're seeing now is a worsening or a new issue. The next red flag is a papyric rash, mottled, ashen or cyanotic. Now, mottling is something that's really, really important to look out for when you assess patients. So there is those pictures are examples of very severe mottling. You can grade mottling and you look around the patient's knee ideally. So you can grade it from essentially 1 to 5, I think, with 5 being the worst, which tends to be the whole leg and up onto the abdomen. Those patients invariably die, but the grade of mottling is essentially proportionate to how severely ill the patient is. If it gets better with resuscitation, that's great. If it doesn't, again, they've got a very high risk of death. And then the next red flag is obviously neutropenic or chemotherapy within 6 weeks. So these patients are particularly high risk. That's where we are at the moment. But as I say, things are changing very soon. I'll talk to that a bit about that at the end. Septic shock is essentially the same thing as sepsis, but with the addition that the patients have evidence of tissue hypoperfusion. Now that requires 3 additional elements to it. So previously it was just maybe if they were just hypotensive or had a raised lactate. Now you have to have all of those things. So a lactate over 2 and a blood pressure 90 or less, and the notional need for a vasopressor to elevate the blood pressure and provide organ perfusion if there's evidence of impaired function, for example, changing cognitive function, low urine output, that kind of thing. So it's a package of things to define septic shock. So that has obviously changed with the new definitions. If patients meet these criteria, this is obviously after fluid resuscitation. If they meet these criteria, risk of death is around 45–50%. So these patients invariably, if they are for full active treatment, need to be on an intensive care unit. Okay, so what if you see someone that identifies somebody that meets the criteria for sepsis? Now, I'm sure most of you will be familiar with the Sepsis 6, which is to come essentially from the UK Sepsis Trust and has been around for about 10 years. Now, this is a standard bundle of care for that first hour for patients with sepsis, and sepsis is listed on the left, and the schematic on the right is actually taken from the Surviving Sepsis campaign, because I wanted to just allude to some of the details around the Sepsis 6 that are so important. Give oxygen if patients need it, really, only if they're dropping their saturations. It's not essential. Taking blood cultures is really important to do, as it is identifying what the source is likely to be and to initiate steps to control it. More about that in a minute. And effective IV antibiotics are currently in UHL. Currently, it's to give a stat dose of meropenem. Now, antibiotic stewardship means that we should be really looking at that, and we are changing it. And it will move towards giving the antibiotic that most likely targets the source of infection that you think is happening. But at the moment, currently, it's to give a dose of meropenem. Measured serum lactate and now fluid challenge if needed. Now, so if I go over to the right, a fluid challenge is not needed for all patients with sepsis. That's the first thing to say. You would only really need to give a fluid challenge if the patient either has an elevated serum lactate above 2 or their blood pressure is less than 90. Now, fluid challenges should be targeted and should be closely monitored. What we would recommend is to give fluid in aliquots of 500 mils and monitor the response of that. Now, one thing that is evident that patients often get treated for sepsis and given fluid challenges when they may not actually have sepsis. This could be particularly detrimental in patients with, say, a PE or heart failure or severe renal failure. So you could run the risk of making the patient worse if you just piled in and gave 30 mils per kilo of fluid. So the recommendation in UHL and through the Sepsis 6 is 500 mils, review the patient, consider another 500 if they're improving, and this should be under the supervision of someone a relatively senior level, i.e. an ST3 or above. And you shouldn't give any more than 30 mils per kilo, really, ideally, of fluid. Okay. The temptation, this is what we see particularly in the emergency department, is that if they're still hypotensive at the end of that, is to keep going with further fluid challenges. Now that runs the risk of obviously soaking the patient in fluid and causing really serious additional problems. So what we would suggest is that those patients really need to be referred to ICU, and we should really be looking at whether or not they require early vasopressors. Okay, so the temptation, as I say, is to just keep giving fluid, and in some patients that may be necessary, but at the very least, if they're for full active treatment, they should be in an area where they can be monitored much more closely, and yes, give that fluid, but also to think about giving, putting in a line and giving some vasopressor. Okay, and that's towards, again, I'll talk about this a little bit more at the end, towards the target blood pressure of a mean arterial pressure of 65. Now, in terms of targets for blood pressure, resuscitation targets, again, Surviving Sepsis campaign really recommends moving towards what we call dynamic targets rather than static ones. So not looking at a single value, but actually really looking at the response to the treatment that we give. So a fluid challenge, and you can look at, for example, how blood pressure has changed, or the waveform of blood pressure, or if you've got a fancy pulse pressure analysis system, you can look at how that's changed. If not, you can look at how the swing on the line has changed. You can look at changes in lactate, etc. So it's really a dynamic process rather than looking at static values. Okay, that's really important. So patients lying on a ward or an ED, so they should be referred to ICU. What we recommend is obviously if they meet the criteria for septic shock, if they have a persistent lactate over 4, they've got a big oxygen requirement, if they've got any other significant cardiovascular problem, or if they're tunded, or if got a significant acute kidney injury. So they're the kind of things that we would expect to see referred to ICU. Okay. So you have at our disposal a range of really great resources to support the care, not only obviously us in intensive care, but there are teams deployed across the trust and on all 3 sites and in the emergency department, and they are there to support the management, particularly the Sepsis 6 delivery, and that's DART, which used to be called the sepsis team in ED. Okay, so they are there to help. On the wards, there are actually boxes on the resuscitation trolleys in the bottom drawer that contain everything there is required to deliver the Sepsis 6. Now, no, these aren't used very much and people don't know much about them, but they are there to help. And if used, will save about 11 minutes of time in delivering the Sepsis 6, so they're there. The other thing that is really important is how sepsis is triggered across UHL. So nerve centre, the process is now semi-automated. So when observations are entered that potentially trigger a red flag by a nurse, that nurse will be prompted to suggest whether or not the abnormal observations may be associated with a new infection. If that is yes, then an alert will go out to across the ward and to the DART team to go and see the patient and confirm and start and support management of the patient. Okay, and it will also there'll also be an alert, particularly if the alert is very high, to the medical team looking after the patient. Okay, so those kind of resources are there to support the management of sepsis in UHL, and I suspect in other trusts as well. So I said I was going to talk about source control. So that leg should have been chopped off yesterday, or certainly debrided yesterday. Source control is vital to saving lives, obviously, with patients. I haven't really talked too much about evidence, but if we talk about IV antibiotics, there is a lot of challenge to how beneficial they are to be given early, but certainly it's fairly true that you need to be giving an IV antibiotics certainly within 3 hours, certainly as soon as possible if you possibly can. Controversial evidence, but Kumar's study from God knows how long ago, 15 years ago, suggested about a 7.6% increase in mortality for every hour's delay. Now, whether that's true or not, there is certainly increased mortality with delay. So first thing is that IV antibiotics given as soon as possible will save lives. Kumar also did a slightly smaller study, which is less well known, and that really was looking at time to theatre for patients with sepsis, and divided the groups into within 6 hours and after 6 hours, and there was a 50% difference in mortality. Whether that was significant or not, because it was a small study, I'm not sure, but it's fairly intuitively obvious that patients with requiring source control for sepsis should go to theatre ASAP. What the College of Surgeons says about this is that patients with septic shock, they should be taken to theatre immediately, and certainly surgery should be underway within 3 hours. That's within 3 hours of patients presenting with sepsis. So that includes the time to getting investigations and reviewing patients, everything done. So actually that is probably a Cat 1 emergency. To patients with septic shock that need source control and come to theatre. For patients with sepsis, then that time window is probably longer, at about 6 hours. But neither observation nor resuscitation should delay source control for more than 6 hours. What this means is that you don't want to have a lethargic surgical registrar saying to you in the middle of the night that, can we just park this patient on the ITU for a bit of resuscitation until the morning and then we'll take them to theatre. That is not what you do with these patients, okay? Their resuscitation should be ongoing as they roll into theatre and have their surgery. You should not allow surgeons to convince you that it's a good idea to resuscitate these patients in ITU. If they've got a belly full of endotoxin, they're not going to get better by lying on an ITU. Okay, so this takes me on now to the ICU management. I've divided up. This is taken from the Surviving Sepsis Campaign guidance, which was last published about 4 years ago. It's readily available, easy to access, free of charge. And if you haven't looked at it, it's worth looking at it. There are lots of other resources as well. I've sort of summarised as best I can a lot of their recommendations. Some of those recommendations are quite weak, but they've tried to stratify them as best they can, and it's worth having a look at them. So first off, ICU, patient comes to us, then antimicrobials. The first is the empiric broad spectrum agent that covers all potential organisms should be given to the patient. That's fairly obvious. But that empiric treatment should be narrowed as soon as possible as you get identification of the bug and its sensitivities. And our embedded microbiologists that we have on all the sites is part of the reason why we have them. Okay. Dosing strategies optimized based on pharmacokinetic and pharmacodynamic principles. Obviously, things like loading doses are going to be really important. Infusions, taking into account kidney injuries, liver injuries, dysfunctions. Okay, and again, that's part of the reason why we have pharmacists working with us. Now, this is an interesting one because I don't think we do this so much in UHL. A combination therapy of at least 2 agents, certainly initially, for patients with septic shock. So that means giving, 2 drugs, for example, something like meropenem and gentamicin for patients with gram-negative septic shock. and de-escalating them. That's not recommended for neutropenic sepsis, interestingly. The first go-to drug for neutropenic sepsis is tazocin. These combinations should be de-escalated as soon as the patient condition allows, as they recover. Maximum durations ideally are 7 to 10 days. We generally give less than that, usually 5 days. But there are situations where longer durations of therapy might be necessary. For example, if someone's got undrained collections within them, or a staphylococcus infection, for example, or if they're immunocompromised, they would all be reasonable reasons to continue longer courses. But equally, on the other side of the coin, a short course might be appropriate if someone has a rapid clinical resolution. All of this should be reviewed daily. And again, something that we maybe not do so much within UHL, but were doing a bit during COVID, is using procalcitonin to guide de-escalation therapy, just de-escalation of therapy. And certainly we're using it during COVID to rule out coexisting infections, weren't we? And I think the magic number is less than 0.5 nanograms per litre. So that might be something that we can think about maybe doing a bit more of. Source control, as I said, this is what the Surviving Sepsis campaign says about saving lives. So source control is really, really important, and really important to get it done as soon as possible. So that means getting patients to theatre. In terms of IV access devices, so central lines, that kind of thing, they should be removed as soon as possible. Now, one clinical challenge that I've seen a few times is the patient with the infected line, and that's the only method of IV access, and you can't get another cannula in. What do you do in that situations? Well, the pragmatic thing to do is to have a go for 20 minutes or so. If you've not got a line in, then to use the potentially infected line to give the antibiotics down and resuscitation if needed. I put intraosseous route there, but intraosseous I know get a bit messy, so you know, I have that as a last resort really. Okay. Fluid therapy. So the resuscitation fluid therapy that I suggested, again, that is something that's really important to get into the patient early when they first present. And in terms of lives saved, again, evidence suggests that the number needed to treat to save a life for patients, certainly with septic shock, is 6, and that's a phenomenally low number. So that's really important to get it right. What do we do after that when the patients come to the unit? Well, as I said, further fluid challenges will be guided by dynamic measurements, and this, as I say, would be things like passive leg raising, which I'm sure most of you have seen on the unit, and looking at the response to that. It might be using echo and looking at the response to fluid, but the key here is dynamic measurements and not just relying on one static figure. Crystalloid as a fluid of choice, which should be a balanced crystalloid. SSC do suggest saline. We don't tend to do that in UHL. And if you're giving large volumes of crystalloid, suggesting adding in a bit of albumin, which I think a lot of us do that. Not using hydroxyethyl starches, they're pretty much gone now. And it favours crystalloid over gelatins as a resuscitation fluid. Vasoactive agents, so as I'm sure you know, the first choice drug for propping up someone's blood pressure if they need it is noradrenaline. As second line, vasopressin, and the SSC suggests possibly epinephrine, adrenaline as a second line agent. We shouldn't be using dopamine. It does leave the door ajar for dopamine in very selected groups of patients, but as a general rule, it's not going to benefit them. In patients with persistent hypoperfusion after fluid resuscitation and vasopressors, suggests dobutamine. I think we would probably echoing these patients and looking at the benefit, pros and cons of that in modern practice now. Either way, whatever drug that you're using, you should titrate it, and if it isn't working for the patient, you should probably stop it. That's really what that says. And they should have an arterial line ASAP to help guide, obviously, the use of these drugs, which is fairly obvious. I've sort of called this adjunctive therapies, really. So steroids have been in and out of favour. As a sort of general consensus now, you'd resuscitate the patient with fluids first and get a bit of vasopressor on. If a small dose of vasopressor is stabilising the patient, then fine. It recommends to use hydrocortisone. We tend to give 50 milligrams QDS and each day, and that's it really. Transfusions trigger of 70 unless obviously the patient's got coronary disease, severe hypoxemia, or is bleeding profusely. EPO has no real role. FFP only if the patient is bleeding or you're planning to do an invasive procedure. Intravenous immunoglobulin doesn't have a role. Blood purification techniques, now that's things like absorption techniques, so washing the blood of cytokines and the like. There has been sort of some up and down enthusiasm for that. We're not using them at the moment. I know the manufacturers are starting to push them a bit more, and there is perhaps some evidence coming through, but as yet I know we're not really using them, but that may change in the future. Anticoagulants, those that are old enough will know that we were stung by activated protein C, and drugs like that, they're not strongly being recommended. Ventilation, really this is just about patients that could potentially develop ARDS, which is obviously a common effect of sepsis. These are all sort of standard ARDS prevention or management strategies, really. So low tidal volumes, limiting peak airway pressures, using reasonable amounts of PEEP, recruitment manoeuvres, particularly if you think someone's got some atelectasis, prone positioning if someone's got significant ARDS and a low PF ratio. High frequency oscillatory ventilation is not recommended. I think use of NIV in sepsis, because it's such a kind of a wide clinical spectrum of patients, they don't really have a recommendation on using that, and I think that's got to be patient focused, really. They don't recommend the use of neuromuscular blocking drugs for more than 48 hours, really, because obviously it causes muscle weakness, etc. If patients have been resuscitated and now developed ARDS, obviously a conservative fluid strategy is recommended. Beta-2 agonists aren't really of use to patients if they haven't got bronchospasm. PA catheters aren't really recommended. And then basic housekeeping, which is full of in the SSC document. So, things like head up, ulcer prophylaxis, and maintaining blood sugars probably below 10, in the sort of 6 to 10 range. We used to go for much tighter control, but that wasn't shown to be evidence-based anymore, or beneficial to patients. Renal support, the recommendations that they say are you could consider continuous or intermittent support, but I really use continuous support in the hemodynamically unstable patients, which I think is fairly obvious. Not use renal replacement therapy purely on the creatinine or urea figure. Really, it should be thinking about acidosis, fluid load, potassium, that sort of thing. That should be the main triggers to starting it, rather than a particular urea or creatinine figure. In terms of bicarbonate support, it's really not to use it to improve hemodynamics unless the patient's pH is below 7.15. Nutrition, it's really anti the use of sort of TPN early on, particularly if the enteral route is available, and not for the first 7 days if you can't use the enteral route, maybe for surgery. There should be an emphasis on starting enteral feeding ASAP as much as you can, either as trophic or hypocaloric feeding, and then building up as the patient's tolerated. The reason for not using TPN is that it's on balance in those first few days. It probably detriments the patient more than it benefits, and can be associated with problems with critical illness, polyneuropathy, and that sort of thing. So it's not recommended. Obviously, in patients that are grossly malnourished as they arrive in ITU, then obviously you might tailor things slightly differently. Supplements for sepsis have no evidence base really, and that includes omega-3, selenium, arginine, glutamine, or carnitine. Prokinetics to improve enteral feeding are recommended, and the possibility of using post-pyloric feeding tubes is recommended as well if they're needed. Okay, so that was a rush through the Surviving Sepsis campaign stuff. So the kind of complications of sepsis, obviously patients on ITU can run into serious problems with encephalopathy resulting unconsciousness and ventilation, ARDS due to inflammation in the lungs, microvascular thrombosis causing a whole host of problems, renal support, limb ischemia, DIC, coagulopathies. These are all common things that we see, and the sequelae to all of that really is death. So in sepsis, so the ICNARC data for UHL, we vary between about 15 and 25% mortality for sepsis admissions. That's against the national average of about 27%. And for UHL, it's about 37 to 40% mortality in septic shock, and it's about 40 to 50% nationally. I know if Ricky's on the call, he'll probably tell us more about renal replacement, but long-term renal replacement is around about the 5% mark of all comers, I would say, for for patients going out. Limb loss, digit loss is about 5-10%. Septic encephalopathy and long-term cognitive impairment is an increasingly recognised thing, and I couldn't put a percentage figure on that, but I bet it's high. There is something called the post-sepsis syndrome, which is being increasingly described, and is very similar to what people are calling long COVID. So it's significant fatigue, lethargy, susceptibility to further infections, that kind of thing, not being able to get back to work, that kind of thing. Post-traumatic stress disorder, as per all very severely unwell patients in ICU, and figures for that are anything from 20, 30, 40% of patients, aren't they? And as we've been seeing with COVID, long-term respiratory impairment in patients that have had severe ARDS will affect a large number of patients and impair their functional status post-sepsis. Okay. So what about the near future? Well, new sepsis 6, that's coming. So it is the same as the old sepsis 6, but one important change is there, and that is that the all of blood taking things, so things like blood cultures and lactate and all other bloods, are all one item of the sepsis 6, and what has been added is a clinical review by a senior decision maker, and that is defined as someone at ST3 or above. So that has to happen in the first hour of the patient's management. That is now part of the revised sepsis 6 as put together by the UK Sepsis Trust. Within UHL, we are moving towards the News 2 version of that. So a News 2 of 5 as a trigger, that should be coming live into Nerve Centre within the next couple of months, and there'll be more promotion about that when it happens. The other things that have sort of been coming out in recent months and years is that there's increasing evidence for the use of beta blockers. So most commonly used as esmolol infusions for patients, that cohort of patients on ICU that have refractory septic shock and severe catecholamine effects, particularly profound tachyarrhythmias. These patients may benefit, and there seems to be accumulating evidence that these patients would benefit from some beta blockade, and that seems to convey some survival benefit. So I think you're going to see this used more and more. Hello?
Sorry, it's Neil. I don't know, you're probably aware that we're starting, or will be doing Stress L at the Royal, which is looking at beta blockade in those that are tachycardic and septic.
There you go. So that's right. So there are, I was about to say, there are further studies going out, and Leicester's taking part in one of those. The other thing that's been floating around recently is high dose vitamin Z plus or minus thiamine. And the first MARIC study that came out in 2017 showed amazing benefits in mortality. And that has not been backed up by further studies, one called Vitamins, I believe, and one called Oranges. And so there may be some benefit there. And again, I think there's some studies ongoing with that. As I mentioned, adsorbers, they may be part of the future, although I'm not aware of any profound evidence. Immune modulation, so whether or not tocilizumab or drugs similar to that will have a role in the future. As Matt is on the call, I thought I would mention infrared thermography, so using infrared techniques to detect microvascular perfusion and generating lovely little pictures to see how mottled someone might be, and help it guiding resuscitation might be part of the future. Something that I think could be beneficial is that the time to in normalizing a patient's blood pressure with septic shock, the quicker you do it, seems to have a significant benefit on mortality. Logistically speaking, when somebody presents in the emergency department or on a ward, but particularly on the ED with septic shock, has their fluid, is accepted for ITU, is then moved to ITU, has a central line put in, and vasopressor started after an X-ray maybe's been done, that can be 3 or 4 hours of hypotension. Before COVID, we were about to start a quality improvement project to look at using early vasopressors in the emergency department. So that would involve possibly putting an arterial line in and starting peripheral noradrenaline on these patients to help normalize their blood pressure. As I say, that conveys potential benefits in mortality. So that is something that might be coming in the very near future. Okay, I've lost my summary slide, but what I would say is that in summary, sepsis is a life-threatening organ dysfunction caused by a dysregulated response to infection. The most important things to save patient lives is to recognise the septic patient ASAP and to give those clear survival advantage treatments, and they are IV antibiotics as soon as possible, fluid resuscitation for those that need it as soon as possible, and source control for those that need it as soon as possible. That is how we save patients' lives with sepsis. Everything we do in ITU is really buying time for the patient to heal themselves. In reality, we probably tweak around the edges, we put the cherry on the top of the cake, but the cake is all done before the patient comes to us. So from our perspective, if we are ever referred a sick patient, we should be thinking, are they septic? And we should also be asking, if they are, then have the patients that are the staff that are referring patients to us, have they done that initial sepsis 6 treatment? And if not, why not? Can they get on with it? Really, that is the fundamental way that we save lives with sepsis. I'll stop there. Thanks very much.
Brilliant, thanks, John. Does anyone have any questions? You guys? No questions there. Neil?
I have a comment.
Okay, Neil.
I think, you know, a lot of what you're saying, John, especially about how we deliver it, is really important. And I think one of the things that we need to aim at is a sort of step down policy from critical care rather than a step up. And that bit about the time to treatment is so important. And we often have this sort of, you know, they start at ward level care and then they have to justify going up to level 3. And actually it almost needs to be the reverse. You need to sort of justify going down to ward level care. And we need to be a lot quicker at doing that. And that's a bit of a mindset shift for us as a group, I think.
So you mean what the default for these types of patients is to think about ICU and then think about a ward once that's been sort of discouraged?
Yeah. A bit like we've done with the laparotomies, I suppose. The default is they have to be considered for intensive care. And what we have at the moment is they get standard treatment unless they're ill. And what we probably need to think is that standard treatment is ICU unless they don't need it. It's just a mindset change that, you know, a lot of patients, the treatment won't be any different, but it will probably speed up that overall. You'll shift the curve one way, won't you, and improve it.
Yeah, I agree with that. I think because it is the mindset of the clinicians that are referring patients to us that we need to impact on. That might create a little bit more work for us, but you know, we shouldn't be frightened of that.
As I always say, our job is to provide critical care, not for tonight.
Yeah. No, very good, Neil. I agree with you.
The question in the chat there, so it's from Maddie, one of the dark nurses. So, if IV meropenem has been given and blood cultures not taken, do we still take blood cultures?
Yeah, I mean, that's an interesting one. So, you know, what I understand by this is meropenem within minutes will have sterilized the blood. Taking a blood culture in that situation, what does the result tell you? If it's negative, then it could lure you into a false sense of security. However, you could still generate, you could still grow the bug that's causing the problem. So, yeah, at the very least, if you're taking a blood culture, you need to document very clearly on it that it's been taken after the antibiotic's been given, so that at least people, when they refer back to it, can see that you know that has happened. But yeah, it's not an ideal situation. It's not one I would recommend that we do. Really, we shouldn't be, you know, aiming to take blood cultures after IV antibiotics. Definitely not. But if it happens, then we've got to be very cautious about interpreting the result.
Roz has just commented, one of the microbiologists, to say that obviously you can still grow MRSA or Enterococcus faecium. Yeah,
so resistant bugs, obviously, yes, that's very right, isn't it? Yeah. So there is some benefit there, particularly complex inpatients who are more likely to have these resistant organisms. Yeah, I agree.
Any other comments or questions?
I've got a question again on the theme of antibiotics. Sort of talking about moving from just giving sort of knee-jerk, giving meropenem, something very broad, and sort of move towards trying to source control on initiation of the antibiotic. Is there any sort of like large data about how this impacts mortality or outcomes of sepsis? Because I imagine there's a lot of challenges to sort of identifying the source on initiation, particularly on sort of medical tape, where a lot of the diagnoses are sort of query chest, query urine.
Yeah, I agree. And yeah, you're absolutely right. And the whole reason why we went with meropenem is after a lot of discussion was exactly that reason, really, where you don't really know for sure what you're dealing with. So yes, but I think we would still recommend giving meropenem in that situation. We'd also recommend it for patients with septic shock, for neutropenic sepsis outside of a hematological ward environment, and obviously for patients that are allergic to penicillins. But yes, I think we have to be cognizant of antimicrobial stewardship. So we are moving towards giving a more focused antibiotic if we possibly can. And the reality is, in the majority of patients that present, say, to an ED, that is generally going to be Carmoxiclav, for the majority of patients. If they've got something going on below the diaphragm, which is more likely to be a gram-negative organism, then I would be recommending something like tocilin or meropenem in that instance, really. But no, for it to be more focused on what you think the source is. But you're right. If you're not sure whether it's above or below the diaphragm, it's really difficult to give a focused antibiotic because you've got to cover everything. Yeah.
Great stuff. Any other questions or comments? Brilliant. That's fantastic. Thank you very much for that.
Good afternoon, all. I'm Dr. Latif Rahman. I'm one of the active medical registrars currently doing 4-month ITU block rotation. And one of the papers that I just wanted to discuss today it's an interesting paper because Dr. Parker said that in the near future there may be a role for immunomodulators in the treatment of gram-negative sepsis. So this is one of the studies they did in India. It was like a multi-center study that they did in India where they tried Mycobacterium W. It's like a heat deactivated form of one of the atypical Mycobacterium organisms, and they tried it in gram-negative sepsis, and they saw what the outcome was in terms of reducing the mortality. So in theory, Mycobacterium W can act as an immunomodulator, which we will kind of have a discussion later in terms of theory behind it. So the study question was, does the administration of MW, which is an immunomodulator, early in the disease course of severe presumed gram-negative sepsis lead to reduced mortality? In terms of the population they chose, the inclusion criteria was any patients with presumed severe gram-negative sepsis early on in their disease process. So how they defined severe gram-negative sepsis was that the patients had to have 2 or more of the following. So they had to have a temperature of more than 38.5 or less than 36 degrees Celsius, a heart rate of more than 90, respirate more than 20, and peripheral leukocytes either more than 12 or less than 4, or there would have been more than 10% immature band forms on the peripheral blood film. So along with 2 of these, they needed to have at least 1 form of organ dysfunction. So it may be a CVS or respiratory or hematological or renal or unexplained metabolic acidosis, and they use different parameters for those. Along with either documented or presumed gram-negative sepsis, and the common infections they kind of used is pneumonia, urosepsis, biliary sepsis, and these were the common infections, the form of infections. And in terms of when they said early, they defined early as still within 48 hours of the first evidence of the organ dysfunction. So that being the inclusion criteria, the patients they excluded from the trial were patients who were pregnant, patients with proven gram-positive culture, patients who had fungal infections as the only source of their sepsis, those who had received CPR, those who were immunosuppressed either from AIDS or from receiving any immunosuppressive therapy, those who had active malignancy, and subjects who were unable to provide consent. So either they themselves or their next of kin being unable to provide consent for the trial. So the patients chosen were admitted in the intensive care units of 5 tertiary hospitals of India. A total of 202 patients were chosen, and through a process of randomization, they managed to do it quite smoothly in terms of 101 patients being allocated to the treatment arm, where they received the MW for 3 days, and 101 patients were allocated to the placebo group. And the mean age of the study population was about 4 years, 40 plus minus around 13.5, and quite significant amount of that population was female, so it amounted to around 70% of the patients. In terms of the design, they randomized using a computer-generated process by a team which were not at all involved in the patient management or the data analysis. The intervention group received 0.3 mL of intradermal injection of MW once daily for 3 days. In terms of controlling the trial, they ensured that both the intervention group and the placebo group were similar in terms of their age, gender, baseline, clinical parameters, and the treatments received. I was hoping to share the table from the journal PDF where it showed kind of their baseline parameters, but unfortunately we've not been able to share the journal PDF. The study was a double-blinded study, so neither the patients nor the investigators and also not the people who analyzed the data knew which group the patients were allocated to. In terms of the outcomes they studied, the primary outcome was obviously a 28-day all-cause mortality. So what they did during the study process was they followed up the patients over a period of 28 days. So those who were admitted, they could follow up directly, and those who were discharged, they either brought them back to their clinics or used telephone conversations if the patients were not willing to come to the clinics. So they followed these patients over a period of 28 days. And in terms of the secondary outcomes they studied, it was the number of days free of ventilators, the number of days the patients were on vasopressors, the length of stay in ITU and the overall hospital length of stay, the rate of infection in terms of the nosocomial infections, the duration of use of antibiotics, and the Delta SOFA score. So how they defined Delta SOFA score was the maximum SOFA score during the course of admission minus the end SOFA score, basically. I'm sorry, the baseline SOFA score. So in terms of the results that they obtained, the primary outcome study showed that in the pre-intervention group, 9 patients out of 101 patients unfortunately passed away, whereas in the control group, the number was 20. So about 11 out of every 101 patients, they found that mortality was prevented, which led to an estimate difference of 0.11, and it was statistically significant. The 95% confidence interval was around 0.101 to 0.21 with a p-value of 0.04. Even though it wasn't one of the outcomes studied, but they did find that the time to mortality was lower in the intervention group compared to patients in the control group. So the intervention group, the time to mortality was 13.5 days compared to 8 days in the control group, and suggesting that it increased the chance, days of survival as well. However, in terms of the secondary outcomes, they did not find any significant difference in the ventilator-free days, length of ITU stay or hospital stay, time on vasopressors, duration of antibiotics, Delta SOFA score, and also no difference in the rate of nosocomial infections. So the reason they chose the Mycobacterium W as one of the immunomodulators, and this is interesting because what the theory behind it was that in sepsis, the mortality is often compounded by multiple cascade of pathways, both down the anti-inflammatory and the pro-inflammatory routes. So because it involves multiple pathways, often historically, any agent targeting any single pathway has often failed to give benefits. And they've also found that in sepsis, even though ultimately it's the pro-inflammatory pathways which leads to a dysregulated immune response, but often a dysregulated anti-inflammatory pathway often leads to downstream problems like secondary and opportunistic infections. So what happens in sepsis is because of dysregulated anti-inflammatory pathways, which would have normally protected you against infections, it leads to secondary and opportunistic infections. And the method by which gram-negative sepsis has been proven to do this is by downregulating toll-like receptors, variety 4, which they call as TLR4. So by downregulating these receptors, this leads to suppressed production of Th1 cytokines. And because of that, ultimately, the anti-inflammatory pathways are dysregulated. So theoretically, Mycobacterium W has been proven to cause upregulation of TL4 receptor activities, and hence it was expected to lead to enhanced Th1 cytokine activity, leading to better anti-inflammatory pathways, thus leading to better outcomes in terms of reducing the secondary and opportunistic infections. And this was further supported by a previous study where it was actually shown that the use of Mycobacterium W actually leads to a decreased rate of nosocomial infections compared to placebo in patients with sepsis. So that is exactly what they tried showing. And as part of the trial, what they did was they measured the interleukin-2 levels in both the intervention group and the control group. And the theory was that the interleukin-2 levels was reflective of the Th1 cytokine activity within the body. So they hope to show that if they could show that the interleukin-2 levels were higher in the Mycobacterium W group compared to the control group, it further kind of added some theoretical justification behind the whole idea that the use of Mycobacterium W can lead to enhanced Th1 activity and thus better anti-inflammatory pathways in sepsis. So in terms of the limitations of the study, one of the major, and in terms of the limitations of its applicability to our local setting, one of the major problems was that the study was underpowered. So the use of 202 patients was in their own admission and inadequate. So what they calculated was that in order to show the same estimate difference of like a 10% reduction of mortality, which this study kind of showed, and in order to achieve a minimum power of 80% and a statistical significant result, they would have had to use a minimum of around 400 patients. They ended up using only 202 patients. So the study was significantly underpowered. One of the other limitations was that the exclusion criteria significantly reduced the general applicability of the study findings. So the cohort of patients they excluded, often these are the same group of patients we often deal with quite a lot. So, you know, the patients with malignancies, patients with immunosuppression for any reason, the pregnant patients. So all these patients actually form an important part of our daily workload when we deal with patients with sepsis. So I think the exclusion criteria significantly reduced the general applicability of the study findings. And one of the other limitations was the fact that in the group of patients that they used, the majority were actually presumed gram-negative sepsis rather than culture-positive sepsis. So the amount of patients they got as culture-positive cases were actually quite low. And when they tried to interpret the results in terms of how many people were actually culture-positive, they actually found that the results were actually non-statistically significant in the cohort of culture-positive cases. So that, I think, was a major limitation. And obviously, we found that they actually couldn't prove the theory. So what they found was that the interleukin-2 level, which I said was reflective of the Th1 activity, was actually similar in both the Mycobacterium W group as well as the control group. So again, that kind of leaves a question mark regarding whether whatever the result they got was actually by chance or whether actually had a definitive scientific molecular backing behind it. And obviously they used 70% of the patients, the 70% of the patients were females, and the age group being, the mean age being 40, this would also not not be consistent with the group that we commonly deal with. Obviously, most of our patients with sepsis often tend to have a higher, tend to be in a higher age group, and we do see uniformly distributed gender. Like the gender is usually uniformly distributed, where this was heavily skewed towards the female group, female population. Lastly, there's a question. There's always going to be a question of whether genetics plays a part. So whether Mycobacterium W plays the same role in regardless of the demography of the patient and their their background, and the region of the world they come from. So these were the major question marks. So when we chose this paper, we were fully obviously aware of the fact that this is a very new study, and it will be ages before anything like this comes into daily practice. But it was just one of the examples of how potentially in the future more and more immunomodulators may be tried and tested in the treatment of sepsis. In the past, I think we know that other inflammation-related modulators has been tried. For example, the most the first thing which comes in mind is activated protein C, which, to be honest, has not been proven to be beneficial. We also have had a number of trials of high-dose IV vitamin C in the treatment of sepsis, and these are basically modulators which modulate the inflammatory pathways in our body. So I'm sure in the future more will follow. So yeah, so that was basically a very short kind of a description of the trial, and something we thought was quite interesting to share.
Thank you for that. Any comments or questions? Yeah, John.
Yeah, thank you. Yeah, thank you very much. That's interesting. The do you have any thoughts about the inclusion criteria of what, you know, how they selected patients that based on their diagnosis of sepsis? Yeah, that's it. What do you think those criteria relate to?
So I think
SIRS.
Yeah, it is SIRS, and that was we departed from SIRS about 5 years ago. So that's part of the sepsis 2 definition of sepsis, and so that suggests that this study is at least 5 years old in terms of its duration of from inception to completion. Do you think that has any bearing on this at all?
So Dr. Parker, when I first looked at the inclusion criteria, obviously this was one of my major questions, because obviously we no longer use the SIRS criteria for treatment of sepsis, and we use the SOFA score. So I think that, like, obviously I do agree that this was one of the major limitations. They ultimately defined, like, included, one of the things was you know, organ dysfunction. So I know now we no longer use the term severe sepsis, because by definition every sepsis is severe. So I think by what they meant by severe sepsis kind of incorporate patients who we would define as septic as per the SOFA criteria. So I think there was a kind of overlap between what we mean by sepsis and what they meant by severe sepsis. Yeah,
I agree. It just blurred the line slightly. It's just that it just tells us that this has obviously been going on. This trial's been going on quite a long time. I think that's what it told me, really. I suspect it's an academic point whether you use the sepsis 2 or sepsis 3 definitions, and it does maybe reduce the impact of the study slightly. But yeah, it's obviously been going on a little while.
About sepsis definitions.
Yeah, use the SIRS criteria.
Yeah. Any other comments or points? I think this just highlights a lot of recurrent issues with trying to study sepsis, which is the fact that it's a vastly heterogeneous disease process with multiple pathogens, which affects multiple different pathways within people who have completely different genetic makeups. And when you try and target one pathway, you obviously aren't going to get the same effect repeated across the population, irrespective if you try and control for what you presume that pathogen might be. And that makes it really difficult to extrapolate it unless you're blocking one common pathway. You're never going to get a big result from these kind of studies, unfortunately.
Yeah, I agree with you, Matt. It's 100 patients in each group, and you're right. It's a massive heterogeneous patient population, the disease process itself, and the only way that you'll get significant answers is to go out to a become, as you say, look at a very targeted thing, or to have a massive multi-center study with fairly pragmatic study design, which is kind of what a lot of sort of modern ICU studies are, aren't they? And is then we saw this with the vitamin C thing, that a small study yielded a positive result, and then when it's repeated in ever bigger studies or on other sites, then that effect disappears.
Yeah. Any other comments from anyone, or points or questions they'd like to ask?
How they blinded the patients, because they were injecting like intradermally, like 3 times a day, and they managed to blind the patient and the investigator.
I presume they all got placebo IM injections, did they?
Yeah, so basically they used similar looking vials, and gave the placebo group intradermal injections of neutral substance.
Okay, so I suppose in that case, if nobody has any more questions or comments, then we'll probably bring it to a close there for today. Thank you very much to everyone for their input. Really interesting session, and obviously very applicable for everyone involved in ICU across the trust. I think next week it might be me actually, speaking about asthma, and then with a couple of papers that are relevant to ventilation. So hopefully we'll see you all there.